This presentation will be given by Varun Dalmia from Albert Einstein College of Medicine in the Bronx, New York.
Good afternoon. My name is Varun Dalmia, and I'm a third-year medical student at the Albert Einstein College of Medicine. Thank you for the privilege of presenting our work on the impact of tibial bypass conduit on long-term primary patency and survival in the Vascular Quality Initiative. We have no disclosures. The prevalence of peripheral arterial disease continues to increase with an aging population, and its most severe form is associated with significant morbidity and mortality. And for this reason, timely clinical evaluation and surgical intervention are crucial for the success of limb salvage efforts. And this is where tibial bypass remains one of the gold standards of treatment. Conduit selection for tibial bypass remains the focus of much research, as great saphenous vein may not always be available, and alternatives are often used for revascularization. This being said, recommendations regarding optimal conduit selection vary throughout the literature, and broad comparisons of conduit types in tibial bypass are limited. Because most current literature limits comparisons to single-segment GSV and the alternative conduit of interest, and vary in study design and approaches, it's difficult to draw conclusions regarding the relative efficacy of alternative conduits. And in addition to this, little is known regarding comparative long-term patient survival across the different conduit types available in tibial bypass. And for this reason, it was our goal to describe and characterize the long-term graft patency and patient mortality of those undergoing tibial bypass based on conduit type and configuration in the VQI. Patients undergoing elective first-time femoral or popliteal to tibial bypass for occlusive disease involving rest pain or tissue loss were identified, and those with a prior history of ipsilateral infrainguinal bypass or with concomitant procedures such as inflow bypass or endarterectomy were excluded. Our outcomes of interest were patient survival past 5 years and amputation-free primary patency at 500 days. And this was defined as freedom from bypass revision, thrombectomy, or graft occlusion, or ipsilateral major amputation. And patient survival and graft patency were assessed with Kaplan-Meier models and log rank for statistical significance. About 3,200 bypasses that met these criteria and with patient survival data were identified, and of these, a little over 2,000 had available primary patency data. Conduit types in our study included great saphenous vein, PTFE and biologic prosthetics, composite grafts, arm vein, and small saphenous vein, with the largest groups being great saphenous vein and PTFE. And although this data was not randomized, patient demographics between conduit types were generally similar. Shown here are survival and patency by conduit type and orientation. Of the great saphenous vein orientations, in situ bypass was found to be associated with significantly greater mortality than the other GSV orientations. Single segment GSV had superior patency compared to multiple segment, and of the prosthetic conduits, PTFE had significantly greater patency than biologic prosthetics. Also consistent with some recently published data, we found that arm vein and small saphenous vein were similar in mortality and patency. When comparing single segment GSV to prosthetic grafts with a vein cuff, there was no significant difference in long-term patient mortality on the left or 500-day primary patency on the right. When evaluating the use of arm vein against prosthetic or composite grafts, there did not appear to be any difference in our endpoints. As expected, Single segment great saphenous vein provided the best patency and patient survival of the venous bypasses. But interestingly, not all of the GSV configurations were equal in long-term patient survival. Our findings of comparable long-term outcomes between great saphenous vein and prosthetic grafts with a vein cuff might call into question the incremental benefit of venous conduit over prosthetic for tibial bypass. And although previous studies recommend the use of arm vein to achieve greater patency compared to prosthetic grafts, our data suggest that long-term outcomes are similar between these two conduit options. Our study does have some limitations. Clinically, single-segment vein will most likely be used if available, and in patients undergoing tibial bypass with alternative not conduits, it's very likely that single-segment GSV was not an option. And for this reason, we did not conduct multivariate analysis. Using the VQI dataset, we were unable to evaluate parameters such as preoperative vein diameters or outflow quality, or endpoints such as wound healing and changes in ambulatory status. And finally, some of the less frequently used conduits had smaller sample sizes in our study. So in summary, optimal conduit selection in tibial bypass in conduit-limited patients is not well defined. We use the VQI database to compare long-term outcomes by conduit type, and our findings suggest that conduit choice may not be the single overriding factor in long-term tibial bypass outcomes, and factors such as vessel quality and outflow may be even more important. Our findings also suggest that prosthetic conduits may not be as disadvantaged as previously thought, and might not ultimately impact long-term patient survival or primary patency. Thank you for your attention, and I'll do my best to answer any questions.
Thank you very much for that wonderful presentation. And let me just again congratulate you for this extensive work. You said at the beginning that you were a third-year medical student, and I think it's tremendous to see somebody in your status right now doing such advanced database research and getting involved in our society. So welcome today. I'm glad you're joining us and presenting this, and want to just again congratulate you on an absolutely excellent job. Thanks for being here to take some questions. Oh yeah, absolutely. Let's start off. We have a question by Dr. Corrier, who asks whether vein graft orientation, meaning reversed versus in situ, correlated with surgeon. Some surgeons have a way that they like to do it versus picking what might be considered better. Did you notice any association between surgeon or even institution at that matter for the VQI and graft orientation?
Yeah, so at the at the level of how we did analyze the VQI data that we had, we didn't actually look at surgeon or specific center, at least in this analysis.
Wonderful. I have a question by Jordan Stern. How many patients had available follow-up data at these long-term time points? VQI tends to lose its sensitivity and fidelity after about 1 year follow-up because it is designed to be a 1 year follow-up database for most of these endpoints.
Yeah, so out of the total cohort was about 3,200 at the start, and patients with primary patency data up to 500 days. The follow-up was around 2,000 patients.
Okay. Jeannie Ruddy said, nice presentation. And could you please elaborate on the decision to eliminate those with a concurrent common femoral endarterectomy?
Yeah, so I mean, the decision to exclude patients with concomitant inflow interventions was made particularly just to make sure that we weren't that wasn't a confounder in terms of it wasn't a confounder in terms of primary patency.
Okay. Gregory McGee asks, or says maybe I missed it, but was the impact of the indication for these bypasses, was it all CLTI or was it claudication as well?
The indications were, critical limb ischemia, so rest pain or tissue loss.
Okay, because we do usually see different survival curves for claudication patients versus CLTI patients. And some of the survival, I personally wondered as well whether these survivals are really good, and made me wonder if there were some claudicants in there. Do you have any information about the technique on how the vein cuff was incorporated with a prosthetic bypass?
Yeah, so in the VQI data, we're actually limited in terms of like the orientation of vein cuff, or if it was like a specific orientation of vein cuff, or if there was like a prefabricated cuff. So that is like one limitation to like our conclusions of prosthetics with vein cuffs.
Yeah, I know some of these granular details are hard to glean from these large databases where it's essentially a yes or no checkpoint, was an adjunct used or not. Have you been able to see one of these at your institution, and do you have a sense for how they do a vein cuff with the prosthetic bypass?
I have not personally seen a prosthetic bypass with a vein cuff. I've seen those with prosthetic bypasses though.
Great, thank you. A question from Hipil Chang. Thank you again for such a great presentation. The VQI infrainguinal bypass module includes patients with aneurysm as well as occlusive disease. Did you exclude patients who had aneurysm disease?
Yeah, we did. Our cohort only included patients with occlusive disease.
Okay. A couple other questions I had regarding the VQI data set specifically. I haven't heard many presentations use the primary outcome of amputation-free primary patency. We often talk about primary, assisted primary, and secondary patency. How did you come to choose amputation-free primary patency as your main outcome?
Yeah, so I'm glad you asked that question. So originally we used amputation-free primary patency in order to capture patients who had amputations, who underwent amputations even when their graft was still patent. But since then we have reanalyzed our data using outcomes of amputation-free survival and primary patency. And the conclusions that we made regarding that like prosthetic grafts with a vein cuff had similar amputation-free survival and primary patency to single segment great saphenous vein, as well as that prosthetic grafts had similar outcomes to arm vein. But we did change those outcomes to remain more consistent with literature and with reporting guidelines.
Okay. And you're saying you did not notice any significant differences in the outcomes rates between those two groups?
No.
Dr. Corrier asks if you included patients to also have a toe or forefoot debridement or minor amputation at the time of their bypass or thereafter. Often we do these for limb-threatening ischemia, gangrenous toes, and ulcers, and they do need a therapeutic amputation to treat the infection or gangrene. Were those captured, and did that affect your outcome?
So our outcome only included major amputation, so below knee or above knee.
Okay. A question I had is whether you analyzed adjunctive anticoagulation use. I know the VQI modules usually record whether somebody is taking, say, an anticoagulant or an antiplatelet therapy when they come into the hospital and when they're discharged, and then at their 1-year follow-up. Did you look at those and whether there was any association between taking antiplatelet or anticoagulation and improved patency of the bypass?
So we didn't look at those in our analysis. However, like that data is available in the VQI, and that's certainly something that we could look at in the future. I know that there have been previous studies that have shown that patients taking anticoagulation who underwent tibial bypass with a prosthetic conduit had similar outcomes to those with single segment saphenous vein.
Okay. And then the other question I had is whether you have a sense of how many of these were index treatment for limb-threatening ischemia, meaning the first procedure the patient ever had, or whether these were bypasses after a prior failed endovascular procedure, now reverting to a bypass. And if you could tell if there was a difference in either survival or patency in one of those groups versus another.
Yeah, so these are the patients included in our cohort were patients who underwent first-time tibial bypass, and they were excluded if they had any prior history of percutaneous intervention.
Okay. And you also have a sense on assisted or secondary patency, meaning how many of these bypasses that failed were able to be reopened and kept open thereafter?
So in our analysis, we didn't look at that, but I think that's definitely a good avenue for further research, especially given our conclusions that primary patency is similar. I think looking at reintervention rates and secondary patency will be important to hash out the differences between these conduit options.
Wonderful. Again, great job on your presentation, and also a wonderful job dealing with these sometimes tough questions. I want to congratulate you again, and thanks for being here tonight.